Bismillah. Today we will start our first lecture in the first module of Clinical Pharmacology Mastery or Clinical Pharmacology in Practice. Actually, before we start, I would like to highlight why I choose this topic and why I establish this course. From my experience, I found that there is a huge gap between the knowledge and the practice. And this gap, unfortunately, the pharmacists not fill properly because they have a lot of knowledge, and I don't flatter them if I have said that the pharmacist considered the highest level uh, education staff having knowledge in between all healthcare team. Why? Because they are the only members which are drug expert. For example, the physician, whatever his qualification and professionalism, they know only about the medication a limited knowledge related to their specialty. And the nurse in concern also, they know how to drug administration according to their scope of service. But the pharmacist, they are the only healthcare team professionals which they know each single information needed to do a proper medication management. But in practice, the knowledge is huge. So my turn in this course to pick up from the knowledge which information I needed really in practice and I can utilize it to simplify the knowledge and to use this knowledge in the practice in a proper way. So I established this course, Clinical Pharmacology Mastery, and this is our first module to talk about the fundamentals and the principles, basic principles about of clinical pharmacology. Let me introduce myself. My name is Ahmed Sabri. I am board certified pharmacotherapy specialist, MOH registered pharmacotherapy specialist, clinical pharmacist in AQWCH in UAE. We talk about these principles. We will dive in the memory to try to memorize some old information which we studied in our college related to the basics of the pharmacokinetic and pharmacodynamic of the medication. But before it, I want to differentiate between three terms. What pharmacology, what clinical pharmacology, and what's the difference of both of them than clinical pharmacology in practice. I'm sure that you know, for example, in the patient with heart failure, we use beta blocker as a medication management for this chronic disease, heart failure. But if I ask a question, can I use any beta blocker for heart failure? For example, if I ask it, can I use labetalol, for example, to patient has heart failure to improve his case? Kindly you can answer in the chat. If it is not easy, you can use a mic, whatever it is more easier for you. My question, labetalol can be used as a beta blocker in treating of heart failure?
لا no I know only three medications only three beta blockers we can use
Yes,
them.
yes,
I
perfect.
know as I remember bisoprolol,
Bisoprolol,
we
exactly,
we
excellent.
carbi we carvedilol,
Carvedilol, okay. And what is the third
and
one? You
the
remember?
third one no I don't remember.
Metoprolol, MBC, MBC, metoprolol, bisoprolol, carvedilol. Yes, perfect answer. But if I ask why, already the beta blocker it is stated in the guideline to be used as medication management for heart failure. Because their mechanism, we know that heart failure, I need to reduce the heartbeat. So beta blocker will give me this effect. But why only three medication can be used only in heart failure. This is the difference, the clear difference between pharmacology as a science of mechanism and the clinical pharmacology as a science from practice, science of research. When they make research, they found the only three effective beta blocker can be used in heart failure, only these three. So this is give me like a clear view that not only the knowledge can be used in practice directly without applied in the real world and see what is the real outcome. Clinical pharmacology in practice means if I give all patients, my question, if I give all patients with heart failure, any one of these MBC medication, metoprolol, bisoprolol, carvedilol, I will get the same outcome. All will be improved on the same way. Can I have an answer?
Not depending on the patient conditions.
Exactly, depending on patient condition. And this is what means clinical pharmacology in practice. So the knowledge, this here, our rule or the rule of our course is to pick up the practice point of the knowledge, what will happen in the real world. Because because if we applied the knowledge in practice, we will get always outcome. This outcome, it will reflect for me if this knowledge is enough or I need further research to improve the knowledge. Actually, I want to tell you something. There is triangle between practice and the knowledge and the research. First, I have a knowledge. Yes, guideline give me this information. It is clear that metoprolol, bisoprolol, carvedilol can be used in heart failure management. Exactly. But I will apply this knowledge from guideline in the practice. Anyone of heart failure, I will give him either one of these three medication. Then I will see the outcome. If they totally improved, then okay, this information is 100% clear, accurate. But if there is no 100% improvement and some of this medication, and this is what is real happened in the practice, some medication not improved on one of these MBC medication, beta blocker medication in heart failure, which means that I need to make further research why the patient which is not improved, which are not improved. I know I want to know the reason. So I will like investigate more and I will screen the patients which are not improved with these three medication to pick up some new information need to be research, make further research again to see which patient exactly can be suitable to treated by one of these beta blocker to get me the best outcome and improvement from heart failure. Now I think this is clear point for you that this triangle from practice I will make a new research and from new research I will get a new information to update guideline. Because of this, the pharmacist, all healthcare team, but especially pharmacists, they must, if they want to be unique from a lot of pharmacists all over the world, they need to be always update about what is the new in the guideline because guideline always updated according to the new outcome come from the research. I hope this point now is clear for all of you. And let's jump to the next point. If anything from introduction is not clear, kindly just ask me to clarify again. All clear?
Yes, doctor.
Okay. Actually, also for this purpose, I established academy called the Dr. Pharma Academy. Inshallah, later on, I will send you the site, the website of this academy, and inshallah, if all our lectures and most clinical tips in practice, it will be published also on this academy. Okay. What is the content of our first lecture in our course, Clinical Pharmacology in Practice? First, we talk about clinical pharmacist compass. American uh, American Academy of Clinical, American College of Clinical Pharmacy. Actually, this organization is one of the high level international organization which support clinical pharmacy practice. It is the organization which establish the American board of different pharmacy specialty, pharmacotherapy and nutrition, pediatric, cardiology, critical care, whatever, according to near, I think, near to 23 specialty in clinical pharmacy. They have the like 8 standard in the clinical pharmacy practice. We will go through it. Second part, precision engine. We talk like fast view review about the pharmacokinetic difference than pharmacodynamic and the clinical algorithm. Also talk about absorption, distribution, metabolism, elimination, and some pharmacokinetic equation like T half, creatinine clearance, volume of distribution. And this in practice, actually, maybe while you was studying this, it was some boring. I know the pharmacist always hating like calculations, but actually, this in practice, from my experience, I can tell you this is like core information. Each pharmacist wanted to practice a clinical pharmacy in a proper way, they must know this equation properly, and they must know when he need to apply it in the real practice. Pharmacodynamic also, we will talk about like antimicrobial framework, what is the bioavailability, what is the Cmax, what is the minimum inhibitory concentration, and how to apply it area under the curve, and which medication I need to apply this equation. And also in a special population, why some patient before giving the medication I need to know the history, to know this patient either renal, hepatic, obesity, this according to age frame, he's neonate, infant, elderly, and what is the most critical drug interaction, and what is the principle in drug interaction I need to understand properly. Therapeutic drug monitoring, when I apply it, adverse drug reaction, what is the most common. Pharmacogenomics, this is the most updated pharmacy branch. Now the world, I'll talk about like some medication, some patient have some genetic hinders or genetic information. Like, I can't give some medication for them because of this genetic map. This also we will take a review about this. What is the worked clinical cases? How the multidisciplinary team in the hospital contact with each other in the hospital setting, the healthcare team like physician and the nutritional and the pharmacist and the nurse, they are not talking like as our simple language which we are talking in the community. No, they are talking by a clinical language. This clinical language we need to know, like soap format. Any clinical pharmacist, he doesn't know how to write soap. Actually, he missed a lot. And the difference in qualification between each pharmacist according to knowing these basic principles in clinical pharmacy practice. Then we will take some question at the end of our module. Then this is a reference. What is the eighth standard of American College of Clinical Pharmacy? These eight standard, it's looks simple from the first look, but actually when you think it deeply, it is something uh, basics, yes, but while applied in practice, it will make a lot of difference. Actually, while I was preparing in my hospital, like a protocol to reduce the medication error, so I make some research to realize what is the meaning of medication error and why it happens. I found that 51% from the medication error coming from prescribing error, coming from the uh, hospital, from the physician. And actually, this because of, as we said in the first of our lecture, that uh, physician, whatever his qualification, he's or they are has a lack of knowledge about the medication, and they need the participate of the pharmacist to fill this leak or to fill this gap in the medication, uh, like dosing, interaction, contraindication, precaution. So these eight principles, if you memorize a lot, you will speak in confidential way with any physician, whatever his level of professionalism. Even if they are consultant, he head of department, whatever. If you are a simple pharmacist, even a newly graduated, and you know these eight principles, then you will feel a lot of confidence while talking or discussing with any physician, even in the community world. First, standard patient-centered care. Just I will excuse the 1 minute. Yes, hello. Sorry for. You see the screen? Screen is clear.
Yes, Dr. Zakli.
Nice. Okay. Now we will start with the first principle: patient-centered care. What patient-centered care? Each medication, it doesn't have a fixed rule. As we say, for example, of our example of heart failure management, if I give all patient this MBC medication for heart failure, I will not get the same outcome. I will get a different outcome. This is the meaning of patient-centered care. That each patient has his unique condition. So before applying one medication for this patient, I need to ask about his history, his condition, his maybe some his level of education also, it will affect my decision. So one of the most critical mistake happen in the community world, for example, community pharmacist. When one patient came to you and they tell you that my neighbor, my relative, or my friend, they take this medication and he is cured, and I have the same disease of him or her. So can I take the same medication? It will give me the same effect. This is the meaning of patient-centered care. Before, of course, any normal pharmacist have no knowledge about this principle, he can say yes, okay, what's the problem? You can use it. If it is cured one, he can cure the another. But the clinical pharmacist, the pharmacist which has high level of education and professionalism, he will say no. I need to know your story first before deciding this medication well suitable for you or no. So this is the meaning of patient-centered medication. Each patient has different story, individualized. evidence-based medication therapy management identify the medication, the patient condition, formulate patient-specific plan, and monitor outcome. Okay. For example, vancomycin. This example, it is happen a lot in the hospital setting. We give a lot of people vancomycin, but we will get a different outcome because one of the different conditions that some patient, for example, has a renal issue, and the vancomycin, as we know, it is nephrotoxic. So if I give the vancomycin with the same dose for the healthy renal patient and the impaired renal patient, of course, I will get a worse outcome. I will get a different outcome for the renal patient. If I give the same dose of healthy patient, I will deteriorate the kidney condition. Second principle, population-based care. Evidence-based knowledge to optimize therapy across population. For example, for pediatric, for example, the neonate, especially we have something happen common in the neonate called septic or sepsis or meningitis. If the neonate means the pediatric population less than 1 month, if I want to give antibiotic for this population for sepsis, any one of you know which is a two medication, two antibiotic only approved to be given in the neonate in this age for sepsis or meningitis?
I don't know, doctor.
Okay, this ampicillin or cefotaxime. These two antibiotic only for neonate category. If the child exceed 1 month, he will shift to infant. He will be infant. At this time, I must give instead of instead of ampicillin cefotaxime, I will give ceftriaxone vancomycin. So the regimen changed according to what? According to the age. So each age when I choose my medication, he has a specific consideration. As a pharmacist, I need to know it. Okay, principle 3, evidence-based practice. What's the meaning? While I am giving my medication, I need to have a clear plan to evaluate my outcome, like critically evaluate and apply current scientific evidence, grade methodology, and RCT or guideline. According to what I decided in the sepsis or meningitis, in neonate I give this kind of medication, and in infant I will give the other kind of medication according to the guideline, which give me this a clear knowledge to be applied in the practice. Principle 4, interprofessional collaboration. This is the language which we said in between the healthcare team, how they are communicate with each other. Principle 5, professionalism. What is the ethical which is applied in the hospital, especially accountable, compassionate practice? These all this principle related to the patient privacy, which I need to protect, and this is related more to the people who work in quality improvement projects. Continuing professional development. This is what we said in the beginning of our lecture. If the pharmacist stopped the learning, it means that this career will not be suitable for him. Actually, if you know, yani, of course, if you search about like job, and if you screening the job through any vacation site like Indeed, LinkedIn, Bait, whatever, you will find that the salary now of the pharmacist reduced till the minimum level of 1,000 dirham per month salary of the pharmacist, which is not suitable for the lowest grade uh, professional or lowest grade any career. And the accountant or whatever, he will take more, much more than this. Why? What is the reason of this? The reason that some pharmacists found that they don't need more knowledge, more education, and they search it, they want to find a proper job with a proper salary without making effort. For example, in comparison to physician, if you set the salary, even in the hospital setting of the pharmacist, normal pharmacist and the physician, you will find a huge gap. Why? Because the pharmacist studied 4 or 5 years or whatever his curriculum, then he graduated, then he stopped learning. But the physician, he studied 7 years as basic principles, then he continued studying till again 3 4 years or whatever till he took the PhD or master or whatever. So there is a gap, a difference in the knowledge. Because of this, the knowledge, be sure from this rule, the knowledge one day he will bring economical beneficial for you. Knowledge will bring money, especially in our life now, which has a lot of research in many fields, not only pharmacy. You found that the people who earning more money, they earning money from like science, from education. So if you stop the education, it means that your value in the market will be less. Day by day, you will reduce your value in the market, and finally, you will not find a chance to have a proper salary to compensate your need. So this is يعني my advice from practice. Try to be always continuous learning. Principle 7, system-based practice. This is what is the rule of our course. How I use my knowledge in a real practice. Understand and improve healthcare system. What is the meaning of medication safety? How I will reduce medication error? How I make quality improvement in the setting in the organization which I working with them? What is the meaning of root cause analysis? The last principle, practice management. How I make advancement of clinical pharmacy service, how demonstrate value and define scope. Actually, these principles, we will go through them in our course in details. But this module, I make it only for like fast review about what we will study, inshallah, later on. I hope till now everything is clear. Kindly, if anything need to be express more or discuss again, just inform me. Is it clear?
Clear, doctor.
Dr. Clean.
Okay. Now we will go about pharmacokinetic and pharmacodynamic, and as you are like freshly graduate, maybe you will be better than me to memorize this information. Pharmacokinetic in a simple way, this what the body does to the drug. I have four principles: absorption, distribution, metabolism, elimination. What concentration will this dose achieve? How long will it stay? Regarding related to the concentration, can you give me one example for one or two example, whatever, as according to what you remember, which medication I need to know their concentration, and this is important point for me as a pharmacist to know their and to measure their concentration inside the body.
Warfarin.
Warfarin, exactly, excellent. What else? Warfarin. How I monitor concentration of warfarin? Do you remember? What is the name of the test?
INR.
INR. Exactly. Okay. What else?
Also for antibiotics like aminoglycosides.
Aminoglycoside. Perfect. And there's also aminoglycoside. It has a different separate topic actually. Okay. What is the tools I will use to measure this? Volume of distribution, creatinine clearance, T half, area under the curve, and bioavailability. Pharmacodynamics. Pharmacodynamics in a simple way means what the drug does to the body. Pharmacokinetic, what the body does to the drug. Pharmacodynamic, what the drug does to the body. I will talk about receptor binding, molecular effect, and the clinical response. What effect will this concentration produce? And what is the meaning of Emax and potency? I will take Emax, EC50, TI, and pharmacokinetic pharmacodynamic indices, and this we will talk in details. But I want to tell something related to the receptor. Do you remember from the pharmacology something difference in effect according to different receptor affinity? I mean, the medication, each medication has a specific receptor, and according to his affinity to this receptor, he will give me the effect. Okay, according to this, do you remember an example for one medication give me different effect, one or two medication, whatever, but they will give me different effect according to different receptor? I will make it easier for you, like epinephrine or norepinephrine, catecholamine in special. Do you remember that alpha receptor and beta receptor?
Yes.
Okay. If the medication work on alpha receptor, like alpha agonist, so it will give me effect on the blood vessels or on the heart.
Blood vessels.
Excellent. Okay. Which means the medication which has alpha agonist, it will give me effect on it will give me effect of vasoconstriction of the blood vessel. Okay. And if it worked on beta agonist, beta receptor, its effect will be on what? Heart on blood vessels.
Heart.
Heart. You know this simple information. How I can use in practice. Do you know septic shock, right?
Yes.
Septic shock means patient got infection and this infection is spread in the blood and they started to make sepsis and the patient got vasodilatation and he got hypotension and hypoperfusion. He got a shock, septic shock. Okay, this is something deterioration. In septic shock, the first within 1 hour the patient should receive antibiotic. Okay, but before antibiotic the patient has hypoperfusion, which means he needs like fluids to improve the perfusion and increase the blood volume. And after the correction of volume state, he need something to make vasoconstriction to be sure to deliver this circulation, this volume of saline or whatever any IV fluid he took it to deliver this fluid to his tissue to overcome or to cure the hypoperfusion. So if I give you two medication and I tell you as a clinical pharmacist which medication I need to use first, norepinephrine or epinephrine in the septic shock. What is the first line? Norepinephrine to يعني remind you working on alpha agonist, alpha receptor, and epinephrine working mainly on beta receptor.
Epinephrine.
Again,
Norepinephrine.
norepinephrine. طيب, I want to ask دكتورة سلمى, why you choose norepinephrine?
Because it works mainly on alpha receptor, and we need to do vasoconstriction for septic shock in order to avoid hypo. This
Okay,
volume.
okay now, دكتورة فاطمة, if I said in the cardiac arrest, the patient, cardiac arrest means what? Means that the heart stopped working. So I need something to work on the beta receptor of the heart to increase the contractility of the cardiac muscle to increase the cardiac output, increase the ability of the heart to pump the blood to the body. So which medication you can use, epinephrine or non-epinephrine?
Epinephrine.
Epinephrine, excellent. Why epinephrine, doctor?
It will work in the heart.
Heart.
Beta
Yes,
2.
exactly. See, simple information. I know it, but it can save many lives. If I am sitting on system verifying medication and I found order of epinephrine for the patient has septic shock, the first order of epinephrine for patient with septic shock, then I will make intervention. A very valid intervention. I will save a life. You know how many cases all over the world died from septic shock? Many, a lot of cases. So by this simple information, I will tell doctor, please start with norepinephrine because we need vasoconstrictor effect more than contractility effect. And if I set on system, I see the patient with cardiac arrest and doctor start with norepinephrine, I will call him, sorry doctor, start with epinephrine to increase the contractility of the heart. So now you know the value of your knowledge if you pick up a specific information and apply it in the practice. Okay, six type clinical thinking algorithm. Now at this time, I think is a 1 minute and the lecture will stop. So according to your preference, do you want to continue or we stop to this level? Do you hear me?
مش عارفة يا دكتور اللي تشوف حضرتك.
طيب 1 minute.